Um, Today we have Jennifer McKenna, Dr. Jennifer McKenna with us. She went to University of Rhode Island for her Doctor of Physical Therapy, and she works at our acute rehab center. She's going to be talking to us today about evaluation and treatment of dizziness. And without further ado, I'll turn it over to Dr. McKenna.
Thank you. Yeah, good morning. Thank you for coming. So again, no disclosures to announce. I'll leave these up for a minute. So the idea behind this presentation came from working with patients on the ARC who presented with a primary diagnosis of like stroke or TBI who also complained of dizziness. And so I was trying to tease through their subjective reports of, okay, well, how much of their dizziness is because they fell and hit their head, or how much of their dizziness is from like an underlying vestibular impairment that we as therapists can address. And then, so we'll go over like a quick intro of anatomy, and then differences between peripheral and central disorders, as well as outcome measures, assessments, and treatments. So it's a lot to kind of get through in an hour. Some things I won't go through in quite as much detail, but if you have questions, let me know. So a lot of authors are recommending that we don't actually use just the term dizziness with our patients, and that we're helping them use other descriptors to describe their symptoms. So dizziness alone would have an incidence of 5.5%. If we include dizziness and vertigo, it increases to 6.7%. And then if you add in lightheadedness and disequilibrium, it adds up to 25 to 35%. So symptom duration can be anywhere from a few weeks to a few months to a few years. The vestibular system declines as we age. So even starting at the age of 30, there's a decrease in the hair cell receptors, and then that continues to decline as we age. So as with most of our patients, it's normal to see a decline in function over time. So if we're looking at, potential decline in vision, vestibular system, and somatosensory systems, then that definitely increases the fall rate as we age. So one group of authors found that there's a 12-time increase in fall rate with vestibular dysfunction, which I think is huge, especially considering how much effort we put into trying to decrease fall risk rate and factors with all of our patients. So it's definitely something that we should be looking at with any patient with balance and falls at home. Another article suggested screening all of our patients who present with falls for BPPV and other vestibular dysfunction. Quality of life is another important factor because of how often people will restrict their basic movement or overall activity based upon their symptoms. So none of our patients will, actively do something that will increase their dizziness. So it's something else that we can have an effect on for them. The three main functions of the vestibular system are to maintain visual images during head movement, maintain postural stability, especially with head movement, and then provide information for spatial orientation. So the VOR is when we're keeping our eyes still and focusing on an object and moving our head. So this is one of the things that we'll see in patients with peripheral impairments, is that they won't be able to maintain their eyes focusing on the object. So if we're moving their head side to side at like a quick rate but small amplitude, then one thing we can pick up on are the corrective saccades, which is on the bottom picture. So their eyes will go past that particular object that we're trying to focus on, and then they'll move their eyes back to keep it in focus. And so VOR times 2 is considered when the head and the eyes and the object are moving opposite with the head. So if we're focusing on an object and then our eyes are tracking that object, but our head is going in the opposite direction. So this is another component that the vestibular system works with. VOR cancellation is when we're actually trying to allow head and eyes to move together. So a perfect example for this is when we're watching a tennis match, and like your head and your eyes are going side to side watching the ball go back and forth. And so it's modulated by the cerebellum to allow us to move the head and eyes together instead of doing the normal VOR. Saccades are when the eyes are moving rapidly back and forth between objects. Smooth pursuit is at a lower velocity than the VOR, and it also allows us to focus on a moving object or on an object. And then optokinetic movement is in tracking of a moving visual field. So for the peripheral vestibular system, it's comprised of a membranous labyrinth. So the 3 semicircular canals detect angular acceleration, and then the 2 otolith organs detect horizontal and vertical linear acceleration. So the main thing is that inside of the ampulla, there's sensory hair cells, and so based upon the movement of our head, the endolymph moves in a certain way that the hair cells get deflected. So if I move my head to the right, the hair cells are being deflected on the right side in a way that they're activating the type 1 hair cells, which are excitatory, and then they're inhibiting the type 2 hair cells on the right side that are also inhibitory. So on each side, we have hair cells that can send excitatory signals and inhibitory signals. So again, if I move my head to the right, then the left side, the hair cells are being deflected in a way that they're sending more inhibitory signals to the brain for that side. So then there's a normal difference in the two sides, and then that's what gets interpreted by our brain as a head movement to the right. So the idea is that when there's an impairment in function, the hair cell, let's say, if I have an impairment on my right side and I move my head to the right, then there won't be enough excitatory signals like there would be normally to make myself know that I'm moving my head to the right. So then if the other component is that at baseline, if I have an impairment on the right side, the tonic firing rate is now decreased as well. So instead of having like the same amount of signals being sent to the brain with my head staying still, now the right side is decreased and the left side is at its normal. And so now that difference is at when my head is still. So now I think that that's what presents with the dizziness symptoms. So now my brain is interpreting head movement because of that decrease in firing or change in firing rate, but my head is actually still. And so that's where a lot of the patients will have their symptoms even when they're not moving. And that's also why patients will present with a head turn to the right, because if my right side has a decrease in firing rate, if I move my head to the right, I'm trying to increase the firing rate on the right and decrease that firing rate on the left. So there'll still be a discrepancy in that firing rate based upon like the extent of impairment, but that's basically the physiology behind why a lot of the patients will be turned to their affected side. For the central vestibular system, there's a lot of connections between the vestibular nuclei, reticular formation, thalamus, and cerebellum that are all coordinated with the overall function of the vestibular system. So the parietal and insular regions are located, or where the locations are for processing, and the cerebellum plays a huge role in modulating how the vestibular system functions. So that's part of the reason why we don't see as good of a prognosis or outcome with central vestibular systems versus peripheral. So then a little bit more with the cerebellum, the different components are used to maintain VOR gain, adjust the VOR duration, or then they're also involved with the vestibular spinal reflex. So again, the VOR is used for stable vision during head movement. The vestibular spinal reflex is used for stable body during head movement. And then there's also the vestibular colic reflex, which is used for stable neck during head movement. So this is just another picture that I thought was helpful to see how all of the connections are working in the central nervous system for the vestibular system. So the idea is that anytime someone has a stroke in any one of these areas, we could see deficits in their overall balance and function. So the common clinical presentation with patients is from a perceptual standpoint. Most patients will have some type of vertigo, and they could have a deviation of visual midline. So again, that happens more with a central impairment. We'll see postural deficits, so again, the inclination of the head or body towards the affected side to basically try to decrease their symptoms. So decreased balance while moving, especially with rotational movements. And then we can also see deficits with ocular motor signs, so that we can have different types of nystagmus. We can see corrective saccades, and an ocular tilt reaction is with based upon certain deficits with a stroke as well. So just kind of going over some different definitions that then we can help use with our patients. So again, dizziness I feel like is very vague. So most of the time when patients say, oh, I have dizziness, I'm like, okay, well, it doesn't really tell me anything. So a lot of the authors were recommending that we're helping our patients tease through, are you feeling problems with your head or are you feeling problems with your balance? So vertigo is when we're sensing or seeing the environment moving. Disequilibrium is when the patient feels more off balance, him or herself. Oscillopsia is when the objects that are stationary look like they're moving. So the vestibular system in this case can't coordinate the eye movements fast enough to keep up with the head movements and also maintain stable vision. As we know, lightheadedness can be related to ortho-BPs or hypoglycemia, so that's something else that we can use from a differential diagnosis standpoint and either rule it in or out. Motion sickness is when there's a mismatch between the visual system and the vestibular system, and then this also coincides more in patients who have migraines. Nausea and vomiting varies based upon the vestibular deficit. So it tends to be more mild in with the peripheral vestibular system, and also like correlates with the extent of the damage. It can also be more involved with some of the central vestibular symptoms. And then if the patient has floating, swimming, or spinning inside the head, that's typically psychological in nature. So here's a list of some different peripheral vestibular disorders. And then just kind of like this is another picture I thought was helpful. I don't know how well it came up, but it shows the two sides of the peripheral vestibular system and then kind of lists or kind of points out like where the impairments would be based upon what they are. So as you know, BPPV affects the semicircular canals. If someone has like a tumor or a schwannoma, that could be more on the vestibular or more on the cochlear part of the nerve or both. So BPPV is the most common cause of vertigo from a peripheral standpoint. So the idea is that the otoconia are floating in the semicircular canal, so similar with how the hair cells are either deflected to excite or inhibit the motion. When the endolymph isn't moving in the same way that it normally does, it creates a mismatch. So with the semicircular canals, they have coplanar mates. So the left anterior and the right posterior canals move in conjunction. So when they're activated, the two of them are sending signals to the brain. So if one isn't operating like it normally would or sending the normal signals, then there's that mismatch, then the results with dizziness or other symptoms. So the telltale sign is when patients get dizzy for a few seconds just rolling over in bed. The symptoms are typically lasting 30 seconds to 2 minutes, and there tends to be a latency. So that's why it may take 10 to 15 seconds after a position change to see the increase in symptoms. And so the test for anterior posterior semicircular canals are the Dix-Hallpike, and then the roll test would be for horizontal canals. So the research definitely supports the use of the repositioning maneuvers as an effective method to improve the symptoms. So most of the time, we can improve patient symptoms in 2 to 4 treatments. If someone has a TBI, it may take a little bit more. The anterior and posterior semicircular canals are treated with the Epley maneuver, which is the most common, and then you can also treat it with the Semont maneuver. And then if someone has horizontal BPPV, you would use the Lempert roll, or it's also called the barbecue roll. The research is showing that the Brandt-Daroff exercises really aren't as effective, so you basically don't need to be doing those anymore. And then I included this into just in case people in outpatient are seeing patients with dizziness and maybe they're not quite lining up the way that you would think. So cerebellar tumors and acoustic neuromas and Meniere's or paralymphatic fistulas have some symptoms in common with BPPV, but the idea is that they're like tumors obviously aren't going to respond the way that BPPV would. So if you do treatments a few times and it's not getting any better, maybe we need to look at like a different canal, or then there's something else going on with patients. So here's just a quick review of the Epley maneuver. I thought this picture was helpful because it shows how the otoconia move through the canal based upon the positioning. And then for the Semont maneuver, you don't need to do as much cervical extension with this. So if you have a patient who can't do that normal cervical extension, you could use this as an adjunct. And then the Lempert roll also requires people to be prone. So if for whatever reason your patient can't go prone, you may not be able to do this as well. So the vestibular neuronitis is the #1 cause of peripheral hypofunction, like aside from BPPV. So then there's viral, there's trauma, and then there's a schwannoma as well. So again, with these symptoms, a lot of times the articles were saying they can resolve in 3 to 7 days, but if the symptoms are lasting beyond 2 weeks, then it's considered a chronic case. So a lot of times with these symptoms, we'll also see changes in patients' like physical mobility, as far as like seeing decrease in head or trunk movements with moving, because again, they're trying to decrease anything that will increase their symptoms. They can have difficulty with standing functional tasks, and especially when eyes are closed or in a darker environment. So if the vestibular system is impaired, then they are relying more on their vision and somatosensory systems. So vestibular labyrinthitis or neuronitis, the main difference is just that the neuritis doesn't affect the cochlear nerve. So with labyrinthitis, you can see deficits in hearing versus the neuritis you wouldn't. So it's the second most common cause of vertigo. And then you can also see prolonged and severe rotational vertigo with this as well. So the treatment typically starts with bed rest and more medication, and then we can gradually resume activity and vestibular exercises for postural stability and gaze stabilization. Meniere's disease or endolymphatic hydrops, the theory behind it is that there's either too much endolymph being produced or the body isn't eliminating it as it normally would. So it causes membranous dissension. The 3 main symptoms are fullness in the ear, reduced hearing, and tinnitus. So it's episodic in nature. So that's why the PT treatment is not indicated for while a patient is having like an episode of Meniere's disease. And depending upon how long the patient's been having it, they may not have any vestibular symptoms in between when they're actually having like the Meniere's disease that's active. So a lot of the articles are saying that over time, the more time that people have this, or the more severe the attacks are, then they may have some residual vestibular impairments in between those onsets, and then that's when PT would be indicated. So typically it's medication, possible change in diet or surgery for the general treatment standpoint, and then PT can be an adjunct, again, in between when they're having the symptoms. The acoustic spondyloma is just when there's a tumor on the 8th cranial nerve. So again, you can have hearing loss, you can have tinnitus, vertigo. The treatment tends to be obviously surgery, so then PT treatment can be indicated after surgery. Perilymphatic fistula is when there's a rupture of one of the membranes. So that's why for this, patients will typically say that they have a pop in the ear. So for here, they'll still have positional vertigo because as their head's moving, the endolymph is moving in a way that it wouldn't normally move. So they can also have nystagmus. Another difference with this is that patients will have an increase in symptoms with sneezing, straining, or nose blowing, which we obviously wouldn't see with other symptoms. So we wouldn't do PT when this is active until patients are healed, and if they have any vestibular impairments then, and the doc clears it, then we could work with them. The bilateral vestibular hypofunction causes are typically from an ototoxicity. So there's a couple different antibiotics that can affect that, or meningitis or different types of head trauma. If you happen to have 2 tumors on both of your 8th cranial nerves, then you can have this as well. But I wasn't sure, I didn't find how common that actually is. So for this group of patients, we'll definitely see more deficits with their overall functional mobility because both sides of the vestibular system is impaired. So they definitely will have more signs for different types of gait ataxia. They definitely would have more difficulty walking in a dark environment, uneven surfaces, or in like a busy visual field because neither vestibular system is then operating to help coordinate those eye movements. Their symptoms also will depend on the extent of the damage. If it's bilateral damage, then a lot of times they won't have dizziness because you don't have that mismatch in signals that are being sent between the two sides. If one side is affected more than the other, then you would see more of those symptoms. For central vestibular disorders, again, CVAs, TBIs, MS can affect the 8th cranial nerve. So of all the people who are complaining of some type of dizziness, only about a quarter of them are presenting with a central vestibular dysfunction. So the symptoms, again, are as listed. So this is, again, a lot what you would see with these patients. And then some other common signs that would present with CVAs versus like a peripheral diagnosis. One of them is skew deviation. So it's when one eye just sits lower in the orbit than another. Ocular torsion is when the eyes are rolling, where the upper pole is toward the lesion side, and then again the head tilting is to the lesion side. So if all of these are happening together, then it presents with what they call the ocular tilt reaction. So it's a combination of all of these, and so it's different ways that the person's moving to help basically use their vision and orient themselves to the environment. So it tends to happen with a posterior inferior cerebellar artery distribution or a medullary infarct. And then this is just another picture showing the anatomy in terms of like where the lesion is, like how the patient may present. So in this picture, the green arrow is the normal subjective visual vertical, and then the red is how things get skewed based upon the impairment. So some other common signs, and some of this was new to me too, the thalamic dysphagia. So what the articles are showing is that based upon where in the thalamus the infarct or damage is, in the posterior lateral central medial region, patients will have postural imbalance and a tendency to fall, but they won't present with dizziness. So these are just some of the things that can relate to changes in subjective visual vertical or subjective horizontal. So lateral pulsion, as a lot of us know, when patients present with what we consider pusher syndrome, it has to do with deficits in the parieto-insular vestibular cortex, and then it also presents with spatial hemi-neglect. So the idea behind this in terms of like why the vestibular system operates is that our central nervous system is factoring in information from vision, somatosensory, and vestibular, and all of that information needs to be factored in together to help us present with like an understanding of what's going on around us. So when the vestibular system is impaired, it also limits our ability for overall spatial awareness. This was another picture I thought was helpful to kind of break out like where the lesion may be in the brain and like what things we may see. So again, with the cortex, we can have pusher syndrome. Same thing with the thalamus. Brainstem is often where we'll see patients with the pusher syndrome. And then obviously there's different types of nystagmus imbalance that can happen with the cerebellum. Vertebrobasilar insufficiency is just another component of what could be contributing to dizziness. And then multiple sclerosis, if it affects the 8th cranial nerve, either where it enters the brainstem or in the brainstem, it can affect that function as well. So TBI, again, as we know, there's different causes from the trauma standpoint, and then these typical symptoms. The test pattern that I found looking through the research includes saccade testing and smooth pursuit performance. So these would indicate more of a central impairment. If we're looking at the head impulse test and that test positive, then that would indicate a peripheral impairment, like with the TBI. So with the TBI, you can have central, you can have peripheral, you can have mixed, or you could have like no true vestibular deficit. So other important questions to ask from like a TBI standpoint are asking them, again, to describe their dizziness, details of the event, to kind of give us a better idea of if there's maybe any cervical involvement as well. And one of the articles was talking about presence of dizziness, nausea, and headaches in the ER after TBI is strongly associated with complaints 6 months post. So again, if we see patients or if we see that on the screen, then that'll help us with a prognostic standpoint. So we also want to screen for cervical dysfunction because of it being traumatic in nature, and we're not quite sure maybe what happened with that initial injury. So they were recommending that we look for the alar and transverse ligament instability just to check for that. If dizziness is relieved by manual traction, then it may indicate like a cervicogenic origin, which brings us into like a cervicogenic dizziness. So a lot of the information was saying that because there's no real thing that we can use to rule it in, it's basically diagnosis by exclusion. So basically you have to look at everything else. If none of that tests positive and there's temporal correlations between the patient's dizziness and their cervical pain, then we could say, okay, maybe it's cervicogenic or probably cervicogenic in nature. So we would still do our upper quarter assessment like we normally would. So the idea is that if we're seeing deficits in the cervical spine and any issues related to that, we would still treat that like we normally would. So we can do manual component for that and vestibular rehab together. So this I thought was another helpful way to kind of look at some of the differences between central and peripheral disorders. So the nystagmus is named for the fast phase, and we wouldn't see like a pure vertical direction with the peripheral lesion. So we would only see a pure vertical direction with the central lesion. The vertigo tends to be more intense with a peripheral lesion because between the two sides, they're not sending those correct signals to the brain. So it's less common with a central lesion. But again, the lateral pulsion or like deficits in subjective visual vertical would link with the central lesion. Ocular motor deficits, smooth pursuit and saccades would be abnormal with a central, versus like a VOR would be more indicative of a peripheral lesion. And then the red flags, I included this again based upon if we're seeing patients, maybe an outpatient with peripheral, and then we're picking up on symptoms that aren't coinciding with what we think they should present with. So horizontal or vertical diplopia that lasts longer than 2 weeks, or like a persistent pure vertical nystagmus would be more of a central lesion than a peripheral. All right, so switching gears a little bit more like into treatment. So I found this definition that vestibular rehab is based upon improving the natural phenomenon called vestibular compensation that occurs after acute vestibular disturbance or chronic congratulal misbalance. So the first time I read this, I was like, all right, I still don't really know what that means. But the one thing after reading through it more is that the vestibular compensation is basically how the brain is trying to heal in itself. So when we're talking with each other, talking with patients, we typically use compensation to say, okay, the patient has balance deficits, they're compensating by using the walker, or they have this deficit and they're compensating by using this other component. So central compensation is really just how the brain is trying to heal on its own. So just to kind of keep that in mind when we're talking with each other or explaining with patients. So the main idea behind vestibular rehab is that we're trying to use our other senses to have the patients use them to improve their balance while the vestibular system is impaired. And then we're using the idea of central compensation like to our advantage. So there's 3 main components: adaptation, substitution, and habituation exercises. The adaptation is when we're purposely trying to increase, let's say like a retinal slip. So we're purposely trying to create an error with the head and eye movements to get the body to adapt. Substitution exercises are when we're purposely looking at using vision and somatosensory systems to substitute for the loss in vestibular function. The habituation exercises are when we're finding particular movements, such as maybe rolling over in bed, turning around, reaching up for a high cabinet, or reaching down for a low cabinet, that are increasing the patient's dizziness symptoms. So not necessarily like a VOR deficit, but they're just improving or increasing their symptoms, and then using those exercises for desensitization over time. So the APTA came out with a clinical prediction guideline in 2016. So they also include the adaptation and substitution exercises, but they count that under the one category of gaze stability. They include the habituation exercises, and then they added to that general balance and gait training, and then walking for endurance. So like I had mentioned, a lot of these patients will decrease their mobility, decrease their overall activity because of the dizziness that they're getting. So that increases their decreased activity tolerance and deconditioning, which obviously, as we know, kind of spirals into overall decrease in function as well. So the indications from the APTA guidelines include for unilateral peripheral lesion for acute, subacute, and chronic, and then bilateral. And then other articles are also recommending for postural training, and then anytime there's vertigo or dizziness or unsteadiness, we can do this as well. Contraindications would include anything that's unstable. So Meniere's disease is a good example, paralymphatic fistula. If there's a sudden loss of hearing, then they would need to get that checked out as well. If there's any discharge from the ear and the nose that could, after a surgical procedure, that could potentially be a CSF leak. And then if there's acute neck injuries that we wouldn't be able to do our typical cervical motions with, then we would hold off on this as well. So the head impulse test is assessing the VOR. So this is the best way that we can use to differentiate between a central and a peripheral lesion. So we're taking the patient's head, moving a little bit slowly, and then doing one quick rapid movement. So it's a high speed but short range of motion, like a small amplitude, and we're having them focus on our nose. So then we're looking at their eyes to see if they have that corrective saccade. So if their eyes go past our nose and then come back, then that would be a positive head impulse test. VOR cancellation we can look at from a cerebellar standpoint. So if they have a cerebellar stroke, we can look at this, or if we're trying to rule things in or out. They won't be able to do the VOR cancellation if the cerebellum, or that part of the cerebellum is impaired, because they don't have that modulation factor. Smooth pursuit and saccades are when or smooth pursuit is when we're having them track an object, so kind of like that H pattern. And again, that and the saccades are indicating the central function. The head shaking induced nystagmus test has shown to really not be that sensitive, and it wouldn't really give us too much information whether it's central or peripheral. If we put the patient in a dark room and give them, I was thinking like a glow stick, if we don't have anything more involved than that, and have them hold that glow stick where they think horizontal or vertical is, and if it's off by 2 degrees or more, then that would indicate a subjective visual vertical or horizontal impairment. The positional testing, like we know, is for BPPV. And then dynamic visual acuity, so you have them looking at like an eye chart and have them read the lowest level that they can statically, and then you have them oscillate their head at 2 hertz, which comes about to like 240 beats per minute, and you can use like a metronome for that. And then you ask them to read the line that they can read clearly while their head is moving. So you're looking for a change in the lines by 3 lines or more, and then that would indicate a deficit in their vestibular system. It doesn't differentiate out central versus peripheral, but it is something that we can use to help know about their reading ability, and then also use as an outcome measure. The rotary chair test is considered the gold standard for bilateral vestibular hypofunction, but this is something that they would do in like outpatient, like an ENT's office, and then caloric testing is something else they can do in that setting as well. So these are just a list of some different outcome measures that were used in the different articles. So the dizziness handicap inventory, we're looking for a change of 18 points or more to be clinically significant. The activity-specific balance confidence scale, we're looking at a score of 67% or less to indicate a fall risk. The modified clinical tests of sensory interaction on balance and the functional gait assessment are also used a lot for these patients. We can use timed up and go, we can use dynamic gait index, the mini best, or 5 times sit to stand as well. So looking over a little bit more into the treatment component, the goals are to improve postural control, decrease dizziness, and improve visual acuity with head movements. So just like anything else that we do, our interventions and the patient's progress is based upon the exercise specificity. So when we would start doing things in a seated position for safety purposes, but then we would also need to progress like the rate at which we're doing it and all the distance. So a lot of times they would say start with the objects like an arm's length away. Well, you would want to vary that as well. So you'd want to bring it closer, you'd want to bring it like a little bit farther away. You would want to have them have their head be in different positions in different environments, so like standing in a busy visual environment or like in a quieter space, and this way that we can kind of get all aspects of the vestibular system function. The one good thing is that the patient's ability to respond to vestibular rehab doesn't change over time. So as we know, the vestibular system itself can impair with age, but the body's ability to respond to vestibular rehab isn't negatively affected by age. So again, with other comorbidities, you may not see the same rate of progress, but it doesn't mean that they won't benefit from vestibular rehab. So when we're looking at vestibular adaptation or gaze stabilization exercises, we're doing the VOR on purpose to induce a retinal slip. So it just means that the eyes have moved or things have moved in a way that the image isn't on the retina, and then they have to bring their eyes back to focus on that object. So typically you're asking the patient to move your head as quickly as possible, horizontally and vertically, while maintaining focus on a stationary object. So some of these things you can start with them, and then you can add in for an ETP. And then VOR times 2, again, is when the head and the target move in opposite directions. So one of the things that they were saying about this is that if the patient isn't moving, if they're not quite lining things upright, you may see some nystagmus or something like that. But if you work with them on the positioning, that can improve. The habituation exercises are used, again, when patients are actually complaining of dizziness. So you're trying to find the positions that provoke the dizziness the most, and other positions that don't provoke it as much. So you would start with mild to moderate dizziness symptoms as your guideline, and then use those positions as part of the treatment. So you're looking to remain in this position for 30 seconds or until the symptoms have stopped. And so one of the articles is recommending a home exercise program looking at 3 to 5 reps for each exercise 2 to 3 times a day. So if the symptoms aren't changing or improving in a 2-week time frame, then you may need to change the intensity, and then if symptoms still don't change, then we'll probably need to refer out. The Cawthome and Cooksey exercises were some of the initial exercises recommended for a habituation standpoint. So they use the DHI, dynamic balance, posturography as outcome measures to make that judgment. Another article looked at the modified vestibular rehabilitation program. So it was just a program that they made up on their own, basically, and then did research to show that it was effective. So it focuses more on proprioception and then body awareness, and it still includes the habituation and adaptation exercises. And then another general progression of exercises has been developed through other research, but it's still theoretical in framework, and the idea that they haven't done a lot of testing on it to know, the different psychometric properties. So these are just the Cawthome and Cooksey exercises. So you're starting in bed or sitting, doing different eye movements, first at a slow rate, and then increasing the speed, and then different head movements, again slow, and then increasing that. Then there's different exercises we can do in sitting, and then standing and moving about. So the idea is that when we have patients with vestibular impairments, we don't want to progress them too quickly. So again, we're doing our assessment like we normally would to assess their symptoms. So you can use just like a 1 through 10 scale of their dizziness. So a lot of times they're recommending that we don't increase their symptoms past a 5 out of 10, more like from a safety standpoint. We're also looking at when we increase their symptoms that we're not increasing by more than like a rate of 2. So if they start at 3 and they get to 5, that's fine, we'll stop there. And then the other idea too is that, sometimes patients don't rate their symptoms that well, or you're like, they say maybe they have like a 10 out of 10 dizziness, and like they're sitting there and they look totally fine, and you're like, all right, I don't really believe that. The other component is that you can just talk with them about how their symptoms are and what they feel comfortable with. So as long as they feel okay, you can use that as another way to rate their symptoms. And then again, going from standing to walking. So again, we don't want to progress people too quickly. So once the exercises get easy, then we can look at progressing them. This is the modified vestibular rehab program from that one particular article. And the one reason why I like this was it also adds in suggestions for progression. So it's looking at body awareness training, habituation, adaptation, other balance exercises, and then adding in an HEP, which is important too. And then again, it talks about different ways that we can progress the exercises. Then this was that like theoretical framework, which I thought was helpful. So what they did was they looked at like foot stance and like all the items on that left column. They looked at all of those, and then each component of it they rated based upon the difficulty. So they took like foot stance and all those components of foot stance, and then determined from the research like which was the most difficult, and then the same thing for the surface and everything else. So the idea is that when we're pulling from these different components of how we can change the treatment perspective, then we can kind of keep this in the back of our mind. So even one of the things was they looked at like a slant. So like if someone's standing on like an incline or with a decline, so that's something else that we can add in, because it's, you know, typical to stand on a firm surface and then change the base of support, put them on an unstable surface, but we can also put them on like an incline or then a decline as well, and then different head movements, and dual task as well. So I think that's helpful from a functional mobility standpoint, because people don't operate, you know, in a static way like we often have them like in therapy. So it's like, okay, because one of our patients the other day, we had him like walking around with a cup of water, and he just dropped the whole, like, he had no idea. He just, like, because he has some left neglect or left inattention. So he's walking around with the cup down, all the water has spilled out. He had no idea that that happened, like none at all whatsoever. So how would we know that unless we're adding those things in? So that's why I think adding in the cognitive or manual tasks, like the cognitive component of the tug or the manual component of the tug, is helpful as well from a functional mobility standpoint. And then the VOR, we can add that in even like the background that we're having the patients look at. So they're looking at like a blank wall in a quiet environment, and then adding that into, maybe we're in like Priscilla Herd Pavilion at like lunchtime, and we have them focusing on something and all these other people are moving around. That's another way that we could challenge them. So from a bilateral vestibular hypofunction, the habituation exercises don't work, and a lot of that's just because they don't have that same dizziness. So again, unless there's like a very mild impairment on one side and like a severe impairment on the other, then you would see more dizziness. But so we typically wouldn't use habituation. Their patients are using the other components to compensate since the VOR isn't working. So that's why they'll use the saccades, and they'll try to use smooth pursuit as well. But the idea is that the VOR operates at a function or at a rate that's faster than those. So that's why they can't always compensate for that. The substitution exercises, they found that people typically rely first on like visual senses to compensate for vestibular, and then the somatosensory system. So again, we'll talk to the patients about what we consider like a true compensation with like, okay, this is how you can use your visual system more. Be careful about walking in a dark environment. Definitely use an assistive device for walking. They don't recommend using the VOR times 2, like with the head, like the object and the head moving in opposite directions, because it would be it would create too much of a retinal slip. So VOR times 1 is fine, but they were suggesting that the VOR times 2 is too difficult. So balance training, like I mentioned, and like talking to them about overall safety needs to be involved in patients' program like this. General walking program, aquatic therapy, Tai Chi has all been shown to be helpful, especially from like a balance and overall mobility standpoint. The time frame can possibly be up to 2 years for patients with this to make improvement. So that's, again, something else that we can talk with our patients about, like from a prognostic standpoint. So then switching over a little bit for CVAs, again, balance gait training, like normal things that we would do. Again, like most cases, use varied senses. So like do different things to work on balance. And then a lot of patient education, which needs to be across the board too. So we need to obviously explain to our patients like why we're asking them to do something that will increase their dizziness, as they've been doing a lot to avoid it. And then vestibular rehab can also be helpful to reduce inattention or neglect. So here are just some other exercises that we can do from a treatment perspective with strokes. So different things that we can work on from like a lower extremity strengthening standpoint, weight shifting, and we can start in sitting or supine sitting, and then gradually work up to standing or walking based upon the patient. So the research shows that like our typical balance and vestibular exercises will still work for this do work for this population well. And then we can also do different things to work on dynamic balance to challenge the vestibular spinal reflex. The time frame can be, as we know, it takes a while. So at least 6 months. It could definitely be longer than that. And then longer recovery time at a slower rate than peripheral lesions. And this has a lot to do with how, like all those connections in the central nervous system as well as the cerebellar lesion. So because how much the cerebellum does to modulate how the VOR operates, anytime that there's a central lesion tends to be longer than a peripheral. They found that hemorrhagic strokes had a longer recovery than ischemic strokes. Lesions tend to be, or if the lesion is if the lesion's at the level of the brainstem, the treatment is similar to unilateral vestibular hypofunction. So again, we can start with the habituation exercises and then add in the gait and balance exercises as well. So for TBIs, like I had mentioned, sometimes it can be mixed, it can be central or peripheral, or they could not actually have like a true vestibular impairment, but they could still present with dizziness. So that could be from cervical spine dysfunction, visual perception dysfunction, or autonomic dysfunction. So we definitely want to look at their overall symptoms and how the patients are behaving and how they're feeling. So we definitely would need to start with simple exercises and acquired environment. So these are a group of patients who we may not be able to progress as quickly with the vestibular exercises as others. They typically require basic targets to start with, and we don't want to overexert them. And then vestibular rehab is most effective when headaches are under control. So the modification of exercises with TBIs is that for their ability to re-weight sensory information can be more challenging. So having them in a busy environment with divided attention can be more challenging for them than if it's just a peripheral deficit. And so it's the same idea. When patients are able to sufficiently use vestibular cues for stability with eyes closed, then we can train with a visual and vestibular mismatch. So the optokinetic training has to do with watching things in a moving visual field. So they actually have urban walking videos on YouTube that we could use. So it's a lot of just basically someone walking in a farmer's market or on a busy street in a city. And so you're asking them to watch things in a visual field and move their eyes from one target or one object to another. And then that's what they're talking about with the optokinetic training. So a ball toss is another example because you're having them track that moving visual field. And then we can also look in cervicogenic disorders. So we're looking to treat any hypermobility or decreased range of motion. And again, PT, surprise, surprise, has been shown to be effective to alleviate symptoms. BPPV can occur at a higher rate, or 8.5% to 20% of people with TBI also present with BPPV. So because of everything else that's going on, it's not uncommon for them to need more repositioning maneuvers, but the long-term results are similar. So the repositioning maneuvers are still effective. There was a lot of differences throughout the research from the treatment specification standpoint. So some articles looked at 20 to 30 minutes a day, 2 to 3 times per day, 6 weeks, or just 30 seconds each rep, 4 to 6 reps at a time for habituation exercises, general balance training 2 to 3 times a week. So when we're working with our patients, especially in outpatient, and trying to decide how often they should come to the clinic and what we should do for the HEP, the research is a little bit kind of all over the place. The one thing I think it makes sense too is that 90 minutes 3 times a week and 90 minutes per session 5 times a week had the highest attrition rates. So which most of the time, unless you're in acute rehab, you're not seeing patients for 90 minutes at a time. And even then, when we see them for 90 minutes, we're not only doing vestibular exercises. So the rates or the components that had a lower attrition rate were 45 to 60 minutes at a time, 5 times a week, 40 to 60 minutes a couple times a week. So then the APTA for the clinical prediction guideline, they're recommending at least 3 times a day for a total of 12 minutes if it's acute or subacute. And again, this is for a peripheral lesion. And then if it's chronic, at least 20 minutes a day. But again, the evidence quality is lower, so we're still kind of all over the place from a dosing standpoint. Then if we're looking at discharge from a vestibular rehab according to the clinical prediction guideline, most cases, if goals are met, if they're plateauing, if the patients choose to leave, if there's a deterioration of clinical status or prolonged increase in symptoms, and then the overall length of treatment we're looking at too. But again, from an evidence level, it's still not that high. So other considerations, like I had mentioned, the patient education is really important to help these people adhere to a home exercise program or the interventions that we're trying to help them do. If there's any psychosocial or anxiety issues, a lot of these exercises that are too challenging may just be counterproductive. So that's something else that we would need to take into account. So vestibular rehab can actually be effective for people with panic disorders, even if they don't have a true vestibular impairment. Like I had mentioned, the age doesn't negatively affect someone's ability to participate, and obviously can help improve deficits with ADLs, balance, and gait. And then distal sensation and medical and psychiatric comorbidities, those are other things that we can look at that, again, would negatively affect someone's ability to fully participate. So just as kind of an overview, the one good thing is that there's strong evidence that vestibular rehab is effective for adults with acute or chronic dizziness, like unilateral or bilateral peripheral hypofunction, as well as for central lesions. There's significant improvements that can be made in posture control with the VOR function, subjective dizziness, and quality of life, which again I think is very valuable. And then one of the articles was looking at, is it better to do like one-on-one training or group training? So they typically were saying one-on-one training for acute phase of stroke, or then one-on-one or group balance training for subacute or chronic stroke can improve balance function as well. Just a bunch of. And any questions? I had a lot of information, so I don't know if sorry if I went a little too fast through all of that, but are there any questions or comments?
You said how many reps of the VOR?
A lot of times they're looking at like to do things for 1 minute at a time. So that's why they were also looking at, like when we talk about like the dosing from like what the patients can tolerate, they were recommending that, again, we can do it at different speeds. So ideally for the VOR, you'd want to do it at like a faster speed just because that's how the VOR functions on its own. But if the patients can't tolerate it for a minute, then you can start at a slower rate so they can do things for a minute. So same thing with like the other like habituation exercises, like you're trying to, or the other like VOR head movements, the CODs, like you're trying to do it for a minute at a time. So you can explain that to the patients and kind of use that as your guideline. I don't know if there's any other questions or anything. Thank you.
So just make sure you sign in New Jersey. Make sure you also sign out and pick up your certificate and leave your feedback. Thank you very much, and thanks for the people who attended online.